You're watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. Today's topic, what women need to know once they've been diagnosed with breast cancer. With us, we have Dr. Laura Lee. She is a breast surgical oncologist. Laura, welcome to the program.
Thank you. Thank you for inviting me.
Yes, we called you, and I'm glad you came down. Now, for people that don't know, you're a breast surgical oncologist. So once a woman has been diagnosed, what is your role in this before we get into the specifics?
So the majority of the time, I'm probably the first physician that sees the person after they've been diagnosed. And I go over with the patients what I anticipate their treatment course is going to be and what surgery they're going to need, whether immediately after they've been diagnosed or further on down the line, and is to coordinate their care.
Okay, and we're talking specifically today about breast cancer.
Yes.
So there's a medical oncologist.
Yes.
There's a surgical oncologist. Going into this meeting, I thought they met with the medical oncologist first, but they would meet with the interventional radiologist, the mammographer.
Right.
Then they would see you.
Yes.
And then you actually tell them their options.
I go over the options with them, refer them to the medical oncologist or radiation oncologist when the time's appropriate for that.
And how long do you spend? I asked you a little bit about this in the green room. So, because this is a very scary time for
Right.
women.
So for a new patient, I set aside an hour and a half for them to come to the office, for me to talk with them, get information from them, examine them, review their imaging studies, and then go over with them what I anticipate their treatment course is going to be.
Are the questions often the same after diagnosis?
In terms of...
Just general questions, like they want to know specific?
They want to know specifics, but I find that I have sort of a pre-planned, and I have information sheets that I go over with each patient that are unique to each patient, that I think the majority of the time it answers the questions that they have, but I give them an opportunity after that to sort of field what questions they have, because I think that the more informed they are, the better choices they make in terms of their options.
Is early detection still the #1 way to wipe this out?
I think it is key to eradicating, giving the woman as many options as are possible, getting the best chance at survival after treatment. It's all based on early detection.
And the survival rates are going up.
They're going
in
up.
stage 1, 2, 3, and 4.
Yes, they have over the course of the last 20 years risen fairly steadily over that time. They have probably reached a little bit of a plateau, but they definitely have improved greatly.
So that's positive. Okay, so our first segment, we're talking about screening mammography guidelines.
Right.
A lot of controversy around this. And I don't want to speak for you, but I've talked to some people, and some people are outraged, doctors in the know. They're saying, I think they should be checked more often. So let's talk about that. What are the current guidelines? What's recommended, and what do you think?
So in 2015, the American Cancer Society, honestly, very much to the surprise of a lot of physicians who treat patients with breast cancer, came out with new guidelines. And it changed when you start screening, as well as, in part of it, how frequently you screen.
All right.
So the new guidelines were that you start screening at 45. From 45 to 55, you have your screening mammograms every year. After 55, to potentially go to every 2 years, after having a conversation with your physician about whether you should continue yearly or whether it should go to every 2 years. In terms of when to stop screening, they have decided now that the benefit from it would be, if the woman is going to live another 10 years, that there's benefit to continuing to do mammography. The difficulty is that previously most women started at 40, or that was the recommended time. And they sort of fudged and said, well, if you're between 40 and 45, maybe consider starting screening if you're in a high risk category or higher than normal risk category, or if your breasts are dense. Well, the problem with that is, for most women, they don't know. They may not know the density of their breast, and the only way that they're going to find out is if they have a screening mammogram.
And just so I'm clear, so the current guidelines, it's 45 plus, but if you're at a higher risk, parent, grandparent, had breast cancer,
Exactly.
sister, then you would start at 40.
Correct.
Okay.
At 40, some people even younger. So there are various ways to assess what a woman's risk is, and it looks at exactly some of the categories that you talked about: family history, history of not only breast cancer, but sometimes other cancers in the family, and if they've had biopsies in the past. Most of the risk assessments do not take into account a woman's the density of her breast, and the way that you would determine that is by doing a screening mammogram. If the woman's breasts are still fairly dense, they are considered at higher risk. Well, most women when they're 40 are premenopausal. Their breasts are more likely to be dense. And so the only way to find out is do a mammogram. So at the very least, I think that we do women a disservice by sort of throwing it out there of you have to know what your risk is and then decide whether you're going to start at 40 or 45.
So you think it should be, what about you personally? Family member of yours, friend of yours, would you say at 40?
At the very least, I would say go and get your screening mammogram. Find out what
At 40?
At 40.
Okay.
Find out what the density of your breasts are, and then you can make a decision as to whether you're going to continue between 40 and 45, or you're going to forego it and resume at 45. Now, I have to tell you that last year at the cancer center that I work at, there were a little bit more than 200 newly diagnosed cases of breast cancer. Of those 200, more than 40 of them were in women who were in a younger age category, so 45 or less.
Are the women getting younger and younger that are getting breast cancer, statistically?
The national statistics don't seem to indicate that, but anecdotally, my personal experience is I've seen younger and younger patients. I have patients that come in their 20s. They're obviously prior to the age that they may start screening. Another category where you would start younger than 40 are women who have a family history. Someone in the family had breast cancer below age 50. And my recommendation to them would be to start your screening mammograms at least 10 years prior to when that person was diagnosed.
Okay. So you're allowed, so the family practitioner, the gynecologist, or whoever normally takes care of women's health, they're the ones that are saying, okay, it's been moved to 45. But I've sat down with these interventional radiologists, one that you know, and they say, Randy, here's a woman that she's 46 years old, never had a mammogram at all, and if I would have just saw her 3 years ago, it would have saved her life. And maybe she won't see her twins grow up. And so there's a lot of that going on. So there are women, I'm careful, I don't want to push you in a corner here, but there's women that might be dying, or there's probably lots of women that are dying because of this 45, this 5-year push-up.
It's also...
Is that true?
I think it is, honestly. Okay. I will tell you, you bring that scenario. I very honestly, in the past couple of months, have had a woman come to my office in her early 40s. She had just had a baby. She had the baby late in life and had never had a mammogram. And she was old enough that potentially she might have had a mammogram a year or two earlier that might have caught this a little bit earlier in the progression. And it makes a tremendous difference in terms of what treatment we recommend.
Catching it early. Like a 1 or a 2 or a 3.
Correct.
We're
at a point, the stages of 1, 2, or 3 where it's potentially still curable.
Okay, let me ask you this question then. Okay, so let's say a woman watches this and you bring up a good point. 40, you might as well check it, find out the density if you're at one of these risks where you should do it every year at 40, okay? But does insurance cover it? at 40?
Currently, it still covers it. So, and it's important, I think, also for women to be heard and to voice their concerns so that insurance will continue to cover it. Because there's a danger that if nobody says anything about it, that ultimately the guidelines roll up to 45 and the insurance companies follow suit and say, oh, well, we're not going to pay for it before then.
Is this one of those things like a dentist, right? You're supposed to see him every 6 months, and less than 10% of the population does that, right? I'm at the age I'm supposed to get a colonoscopy, right? I don't do that. You know, it's like you put everything off. Is breast mammography the same way, where a lot of women, they're like relieved now that it's 45, maybe?
I think there's a certain amount of that they're maybe relieved, or the women who get to 55 and think, oh, I don't have to do it every year. They said, the American Cancer Society said that it's okay for me to wait every couple of years before I do it. And again, it has to be a decision that they make fully informed as to, is it okay for you to go to every 2 years? I think that's what concerns me about the new guidelines is in trying
So you're not a big fan of the new guidelines?
No, I'm not.
Is that an understatement, right? Okay.
That was a polite way to put it.
Way. Okay, so 40. Women at 40, because I mean, we're short on time here. But women at 40, it cannot hurt to go and get a mammogram
It cannot
to find out where you
hurt.
stand. And that, if you get to speak to a real medical doctor, a radiation oncologist, or a radiation, what are they called?
So the imaging.
The imaging person, the mammographer.
So they're a radiologist. They
will tell you whether or not, hey, you should probably check every year.
They oftentimes have in their intake, they interview the patient to ask about those things that we talked about earlier, family history, if the woman has any idea whether her breasts are dense, when she started her periods, is she still having periods, and they use all of that information to assess what their risk of developing breast cancer in their lifetime is. Using that, it helps the woman make an informed decision about, do I need to do this every year? Can I go to every other year?
Makes sense. Now, what about the dangers? I don't want to get stuck on this particular question, but some people might say, I've heard an expert say, flipping through channels actually, so I don't know what kind of an expert, but that smashing the breast or the mammography in it of itself is a little bit dangerous for women. Is that just nonsense?
It's nonsense. And
but have you heard that?
I haven't heard about the compression being an issue.
So
what I have heard women say, and every so often someone will come in and say, I don't want the radiation from doing it. So several things. One is the newer techniques using digital mammography, the radiation is less doing it. The other thing is women that come in and say that they're concerned about the amount of radiation, I will oftentimes ask them, have you traveled recently? Have you flown anywhere? If you flew across the continental United States, you got more radiation.
That's a real comparison? Because I've heard that.
It is
so
more radiation.
So that's not an excuse anymore.
That's not an excuse. That's not an excuse. Now, the other thing, too, that oftentimes has been the argument as they have tried to, or as they have changed the guideline, the mammography screening guidelines, has been that not enough women benefit in that age group from getting screening mammography to offset what potentially the risks are. But what I would argue is that women in that age group from 40 to 45 or 40 to 50, in our society nowadays, that's when you've sort of hit your stride professionally. And if it's the difference between whether you need to have chemotherapy or not, and the time that it takes away from work, your children, your family, or otherwise, we don't have any way of measuring that.
So the earlier you can catch it, you avoid chemotherapy?
Potentially. Now, we make those decisions about treatment, they're constantly evolving. And so it used to be that if you were a younger woman, you were diagnosed with breast cancer, automatically you got chemotherapy. it may or may not be that situation nowadays.
Okay.
So we still use some of the old criteria. We look at the size of the tumor, if the lymph nodes are involved. But I think, again, the earlier it's picked up, the more likelihood that you will have options as to what you want to do, and the better your chances of survival afterwards, regardless of what the treatment
Now,
that
I know
we do.
people always come on my show, and there's a bit of political correctness to a lot of these answers. But do your colleagues, the radiation mammographers, because they're the ones that they're the ones catching it, right?
Right.
And they're the ones that hear the sad stories like you do of people that caught it too late. Are they, I don't want to use the word outrage, but are they frustrated, outraged? Are some of them like going, I can't believe this 45 thing?
All of those words you used, honestly, whether politically correct or not, are appropriate.
So
I
they
do
are
feel
not
like
happy about it.
they are very unhappy about it.
Wow.
And their professional societies are continuing to support, and most of my colleagues, when they are counseling a woman, or if the woman has come in and she's younger than 40 and she's had some issue, they've managed to determine that it wasn't anything to be concerned about, they still continue to tell those women, return when you're 40 to get resume your screening. And I think that that's entirely appropriate, particularly in a woman that has had something happen that at least raised the concern that she was sent for imaging.
Okay, so the takeaway on this segment is at 40, go in, speak to a woman or a man, a mammographer, radiologist, get your screening, get their advice on how often they should go,
Right.
Find out where you stand. You're playing it safe, insurance covers it, and
Or let me put it to
may
you,
save your life.
Put it to you this way: is have your primary care doctor, your gynecologist, send you in for your screening mammogram, and then they will go through some of the risk factors to look at what your lifetime risk of breast cancer is. Women who have a lifetime risk more than 15% should be getting screening mammography at least from the age of 40, should be doing it annually. And if it's higher, there are even some other things that may factor into it. It may be recommended that they have breast MRI. It may be recommended that they have automated breast ultrasound, which is three-dimensional study. But the only way that you're going to know is if you go in at the very least to get that first screen still at age 40.
We are out of time. I mean, this was a 5-minute segment. We turned it to 18-minute segment. But I want to ask you, and I know this is probably a 2-hour answer, but I want it like as short as possible. That was it from the guidelines moved from 40 to 45? Was it to save money, in your opinion? Was it? I mean, were they saying there were too many false positives? It was costing the system too much money? We don't see the benefit.
So it's
Male lawmakers.
It's a couple of those things, and
insensitive
that
to
last
this?
one I will refrain from commenting about. But I think it is.
Do you have colleagues that believe that's part of it?
I do.
Okay.
I think that part of it is the false positives, and I think part of it is this idea of there are not enough lives saved relative to the number of mammograms they do.
Interesting.
And I find that approach difficult, that I realize that we're looking at it as a population and a number, but if it's your family member
Yes.
that loses their life, it makes a lot of difference to you. And the false positives, I think that it's very patronizing to expect that women can't handle the false positives. I think most women would rather know, and if there's even the smallest bit of concern, alleviate it.
Yeah.
Figure it out whether it is or is not something to be concerned about.
Good. Okay. Well, I want to thank you for coming on the program. We're going to take
Thank
a
you.
quick break, and we're going to talk more about testing for genetic mutations.
Okay.
We'll be right back. I'm Randy Alvarez. We're talking about genetic mutations on this next segment. We'll be right back.